On behalf of the Academy of Osseointegration and the Dental Guys podcast, I'm Wes the Dental Guy.
And I'm John the Dental Guy. And here we are continuing with a great day of speakers. And I don't want to waste any time on this one because I want to get right into it. So we have Dr. Christian Coachman with us. Thank you for being with us today.
Great pleasure. Congrats for the project. I'm happy to be here.
Yes.
Thank you.
Yeah. So we're excited to talk to you because, we know that, first of all, we don't have as many people that have the same type of training that you have that are speaking as much with lab training as well as training as a clinician.
Yes.
And then, of course, you've really pioneered a lot of the digital smile design things we've been talking about. Talk a little bit about kind of who you are, where you're practicing, teaching. Just kind of introduce yourself a little bit to our listeners.
Yes. So I'm originally from São Paulo, Brazil, but now living in Madrid, where the headquarters of our company is, DSD, Digital Smile Design. Haven't practiced and worked as a dentist and technician for the last 6-7 years since the business really grew, and that's what I'm doing now. I'm traveling all over the world, spreading the word about all these concepts, and then running the company that basically does education and then services to help doctors implement the ideas that we teach on the courses.
Awesome.
Very good. So one of the things that comes up, I think, anytime we talk about this is creating a virtual patient.
Yes.
We've been talking about this for years and years and years. And the question I think that we want to know is, how much can we create at this point in time a true virtual patient? How much treatment can we do from across the world on a patient versus what we need to still be thinking about in an analog manner? So talk about some of the data we're creating. Can we create this virtual patient?
So great point, because this is the gateway. This is the starting point. Without that, there's nothing happening on the digital environment. This is one of the few things that the clinician needs to really understand, because almost everything beyond that can be outsourced. But creating the virtual patient is done on the first appointment and needs to be done by the clinical team, right? What we have today is very mature technology to generate this avatar of the patient with very good quality and precision that allows us to work completely digital. This digital patient is basically formed by 5 components. We have the facial static information, facial motion, intraoral static information, intraoral motion, and inside the structure information, basically the CBCT. So you have facial scans, facial videos with movements, you have intraoral scans, you have intraoral devices to capture the movements of the jaw, and you have the CBCT. That's the ideal virtual patient. Since some of these technologies are still kind of expensive, the simple version of the virtual patient is just an iPhone and a scanner, right? And the CBCT when needed. The iPhone or the smartphone with 5 simple facial pictures and a video of the face to give the motion, intraoral scans to capture the arches, gum, teeth, and the bite, and the intraoral movement is captured then not in the mouth but replicated by a virtual articulator that works exactly like an analog. So this is the simplified version that every dentist tomorrow can do with a smartphone and a scanner.
So facial scanning, you mentioned that's a technology that's come a long way in the last even 5 years or so. Where is that now? When does facial scanning, the true facial scanner, win over the iPhone, for instance? When would you choose that, or should we be looking to implement that technology?
I think facial scans are already at the level that every dentist can use. Some simple apps, sometimes free or very inexpensive. There's still improvements on the precision of the overlapping of these files, but technology is just growing super fast and improving super fast. So I think that in the next few years, facial pictures will be completely unnecessary because facial scans bring so many advantages. For example, infinitive number of pictures from all the angles and no more wrong angle pictures. That's huge for labs, right? Most of the pictures that we get in labs today are still wrong angle, and then you cannot really work well. So scans take over that, and you can move the patient's face and then make print screens and do the photo protocol out of the facial scans. This is the same we do with the intraoral scans. So Intraoral scans, for me, already took over intraoral photography. Of course, you can be passionate about photography. You can do a lot of intraoral photography, DSLR cameras, etc. Completely unnecessary. It doesn't impact the quality of dentistry. It doesn't impact the quality of diagnosis, treatment planning, patient education, case acceptance, and execution. So the new intraoral scanners with true color coming together, plus the scanner being a high definition camera as well, you can do everything with those images. And I know this is kind of disruptive, and doctors are like, what do you mean? We don't need to do intraoral picture? Absolutely not. Nothing against it. You can complicate your life as much as you want, but it's completely unnecessary today to do fancy intraoral pictures. And you can rely on the images on the intraoral scanner. So facial scanners will do the same with facial pictures. The missing link is the movement. So for the face, we still need a video of the face until facial scanners can start capturing the facial movements, and that will probably take more years to come. Intraoral, the movement, we already have very solid technology and devices and sensors to capture the jaw movement in the mouth. Downside, still very expensive. So the easy or the solution today is just use the virtual articulator that has the same limitations of an analog articulator, but does the same benefit, bring the benefits of the analog articulator, but in the virtual environment. So this is how we manage the movement.
Obviously, our patience is what drove you to be able to like take technology and help our patients be aware of what's possible. And I think one of the things in my practice that I've done with the limited digital smile design that I do with very simple aspects is like even as simple as PowerPoint and showing like how enhanced length of teeth could impact the tooth lip position and all those things that matter to us. Where does 8 and 9 need to go? And so for our patients, really this is where it is powerful. And with powerful software, right? We know the Photoshop world is really not the real world. And so how is digital smile design creating a honest expectation versus a Photoshop expectation?
Good point. First of all, you mentioned working with PowerPoint Keynote. This is what we call the classic vintage DSD.
That's right.
Still useful. Anything that you do to improve your visual understanding of the case and your visual explanation education of the case, visual communication with the specialists on your team, and of course education and motivation of the patient. Any visual tool is valuable. It adds, right? Whatever you do, from old school, pictures that we used to do, drawing over the pictures, and nowadays, of course, in our situation, we do everything in 3D. Expectations. People ask that question. When you generate a smile simulation, the downside is that you create an expectation, and if you don't deliver that, patients will complain, right? First of all, when you jump into 3D, these simulations become much more realistic. Of course, when you design a case, you need to understand dentistry. You need to understand the limits. In the software, everything is possible. So when we do 3D designs, these 3D designs in our lab are guided by clinicians. So periodontists, prosthodontists, orthodontists, and surgeons that are guiding the CAD designers about facial analysis, where teeth, roots and bone belong in that face, what is possible, what is not possible, and then you enter, of course, what is reasonable for the patient, what the patient really wants. So the 3D design needs to be as realistic as possible. Once we define that design, we can simulate the specialty simulations, how much ortho, where do you want to be, how much crown lengthening, vertical augmentation, restorations, what teeth yes, what teeth no, and you define that in 3D. Then comes your question. When we have a very realistic 3D plan, we then generate what we call guided dentistry, all the devices to go into the mouth, guide our hands to try to replicate that as much as we can. We know that is not pure mathematics, and biology plays a big role, and you can have beautiful, realistic simulations, and the outcome can be slightly different. And people say, so that is a problem. And what I usually tell doctors is that, tell your patient, ask your patient, be honest about the fact that these simulations are helping us to diagnose better, treatment plan better, and guide our hands to have outcomes as close as possible to the simulations. Using 3D technology allows us to make mistakes on the computer and less mistakes in the mouth. Period. So you, patient, what do you prefer? You prefer a doctor that is using 3D technology, showing you what is possible, not saying it will be perfect, or you prefer a doctor that says, I'm not going to commit with anything, because then the patient will not complain. You choose as a patient, which doctor do you prefer?
Right.
And it's pretty obvious, right?
Exactly. One of the limitations, just from a maybe more diving down into details on that, used to be tooth libraries that were available to our lab that we, where are we now with that? Because obviously in the end we have to be able to mill or print, whether it's a provisional or a mock-up or whatever it might be. How good is that now, where we can actually have the lab have that available and then be able to make that into something real?
That's another great point. So there's two concepts here that we developed, that we teach, we share with our community. That first one, that is a revolution in restorative dentistry, is what we call copy-paste dentistry. Meaning that once you do a pre-op 3D design, you can copy-paste this into all the phases of the treatment. Meaning that for the first time ever, you can have a 3D design or a 2D simulation that is identical to a 3D design, that is identical to the mock-up, that is identical to the provisional, that is identical to the final restoration, if that's what you want. So that is one concept. The other concept is what we call the natural restoration libraries, meaning that these files, they're not suggested by softwares, neither developed by a human hand. They are scans of real natural dentition. So all our libraries are natural dentition, meaning that your mock-ups, provisionals, and final restorations will look supernatural. And this is much more, it's bringing aesthetics to a more democratic situation where more doctors and technicians can deliver beautiful, natural new smiles if they understand the concept of monolithic restoration. Because the beauty now is not on the stratification, on the layers. The beauty comes from the files, the surface of the file. That's what nature, the gift of nature to us in restorative dentistry.
So rather than having a block of teeth in a library that was created by some mold somewhere or somebody's original hand touch, you're actually saying, and we're not even using AI, right? We're actually scanning, people's teeth, and then using that to create a library. And any
patient that has beautiful dentition that goes to your office can be a smile donator, as we call it, right?
I love it.
A digital smile donator. You can scan the daughter beautiful smile and rehabilitate the mother with that beautiful smile.
That's what I'm talking about.
Right? And that smile donator, I like that. I like
That's
that.
next
you can
level.
scan the patient when they're young and keep those files and rehabilitate them when they get slightly older.
Oh, so edgeware, right, John? Our patients, as they have pathway edgeware, they destroy their teeth. Let's go back to when they're 20.
Actually, instead of just bringing in the picture of when you were 20.
Car accident. You scan the patient today, they go to a car crash, mess up their teeth. Next week, you rehabilitate them with the exact same.
Oh my goodness!
Does that mean that now, because this is changing the way I'm thinking even as we're talking, so that even now when we talk about scanning every patient, even sometimes talking about 100%. Scanning every patient at every hygiene visit, that's becoming a discussion, right? Is this a reason we're actually banking the history?
You want to keep a 3D history of your patient, right? You want your patient not only to be this static avatar, but you want to have this avatar evolving, dynamic through the years. So every hygiene session, scan your patients. And the softwares nowadays, they are able to combine this and create this little 3D movie. And you can start forecasting issues. That's the beauty. So you can see, imagine you scan your patient 5 years ago, 4 years, 3, 2, 1, and you start to compare this, and you can see soft tissue recession, crowding, abrasion, erosion, abfraction, discolorate, everything you can follow.
And I feel like this is where AI is going to start to be interesting. Maybe to be able to predict these changes and catch these in
100%.
Multiple scans
100%.
and then say, hey, here's where we will be projected in 10 years should we not change this, rather than just trying to explain that to the patient. We can actually show them this change.
It's forecast-driven action, because you when you explain a problem to the patient, mentally speaking, psychologically speaking, we human beings, we're trying to find an excuse not to act on that.
Right?
Absolutely. So when you say, patient, you have a problem, the patient tend to think, okay, I have a problem, but it's stable. I'm not going to do nothing about it.
That's right.
When you go back into the past and you created this trend and you show it in 3D, psychologically you create this continuation of a possible worsening of the situation.
And a rate of change is now clear to the patient.
So then the patient says, okay, I can see 5 years ago I was like this, 3 years, and now, oh my God, it's getting worse, and in 2-3 years it's going to get much worse. Let me act now.
The biggest frustration following your career over the last 10 years, really closely and from a distance, is that the companies were not talking with one another. And this I think frustrated you. I don't know. And therefore you created this idea where I can bring everybody in, create my custom APIs, right? Tell us a little bit of how it all kind of came to light.
So we were always very into treatment planning, our passion, comprehensive treatment planning. And companies didn't really understand that, softwares were not developed to help dentists treatment plan. They were developed to help dentists execute after treatment plan.
That's it.
And that's a major mistake from companies, because treatment planning is actually more difficult than executing.
For sure.
We see all over the world many more great clinicians than great treatment planners. So I was screaming to the companies and say, look, we need technology to help us make decisions before we even treat patients, And the only way to have software to help us make decision is to have a software that can bring the basics of modern treatment planning, meaning starting with the face and interdisciplinary connection, meaning all the specialties in the same platform, right? It's like you thinking 10 years ago, 5 years ago, that you could connect Invisalign software with CEREC software, with Dolphin software, with Nobel Clinician software all in one, to allow you to simulate your ideas before even presenting the ideas to the patient.
That's right.
Comparing different ideas, pros and cons, making better decisions to the patient, and visually helping the team to understand this is the best plan to our patient. And then, of course, using these images to convince the patient, to educate the patient and motivate. Then after case acceptance, if you want to do dentistry the way you always did, you already took advantage of the most powerful part of digital. It's decision-making, diagnostics, treatment planning, and patient education. This is the core of success in modern dentistry the next decade. Utilizing smart technologies to understand the problem, build a solution, and sell the solution.
So I got a question then. If you're a young clinician just finishing up dental school, you're joining a practice, and you want to start embarking on just the basics of creating awareness for what's possible in the treatment planning realm, right? Because I feel like digital, well, I won't say what I think because I want to know what you think. What do we need to tell our young clinicians, our associates, future clinicians, hey, this is how you start. Where do you start as a young clinician?
So it's all about the mindset, right? More than investment or learning curve, you need to be open to really understand these new trends and take advantage of these new ideas. As I said, you need to start with an iPhone and a scanner and understand how to create this information. You need to partner up with the digital lab that is a real digital lab, because the hard work is on the lab side. The lab needs to generate these visual information for the clinician to take advantage of it. If you think you're going to buy all the software as a dentist and do it chairside yourself, that is crazy. That is not a smart business model. You create the virtual patient, you outsource everything, and all you need to learn is how to interpret the visual information that 3D technology is giving to you. And interpreting visual information is not digital, it's dentistry. You need to look at images and say, we need to open 3 millimeters of the vertical dimension because I can see the pros and the cons.
So I think you touched a little bit on the outsourcing idea. And I think for years, one of the other challenges was that the dentist wanted to be able to show the patient this, but the amount of work involved in understanding the software, manipulating the software. Both of us have done that, and it is not easy. Now, it doesn't mean that we say because it's not easy that we shouldn't try to master it. But in the end, from a business model standpoint, there is a certain amount of work that we can delegate to technicians that do this 24 hours a day. What does that look like from a laboratory standpoint? You know, how much is the lab doing? How much is the clinician doing when it comes to these designs?
So the first principle here that I follow is outsource to others everything that others can do better than you and cheaper than you.
Good.
Right?
That's good.
Outsource. So do what you do the best and outsource the rest. So as a clinician, you have so much to learn on treatment planning and clinical execution that every minute you spend learning 3D software, I think it's good for you to see, understand, and even try and have a big picture understanding of the complete digital workflow. And this is what we teach on our courses to dentists. Just enough you need to understand about the big picture of technology to be able to be the quarterback of the team.
Yes, yes.
Not be the technician of the team.
Right.
You know? And find a real digital lab that can do everything for you. That is the model to allow you to treat better your patients, to even see more patients, or have a higher average ticket price because you're generating more value to your patients. You're bringing comprehensive dentistry. You're moving from quadrant dentistry, everyday dentistry, into life-changing dentistry. And that is better for your business. So focus on what is more important as a clinician. You know, diagnosis, treatment planning, clinical execution.
Yes.
Understand the big picture and partner up with the people that will allow you to take advantage of technology. So basically, in the modern world, there's 3 teams that will be working together. The clinical team, the manufacturing team, and the 3D treatment planning team. So you need to find your 2 partners. Who's going to be your treatment planning, your digital 3D treatment planning team, and who's going to be your manufacturing team. Many labs, I call labs as manufacturing centers. They know everything they need to know to print and mill whatever they need to do. But there's a new team that is that started to happen in dentistry, and that is the 3D treatment planning team.
Oh, I totally love it.
Yeah.
So this is good. People that have, these are companies that many labs will become treatment planning centers.
Yes.
Right? Some DSOs will build their own treatment planning centers. Implant companies are already investing in
Absolutely.
our DSD planning center model that needs to be spread out because we cannot serve the world.
Right.
We are small. So the treatment planning philosophy, I think, is going to play a big role in the near future, and many companies will become that. What means becoming that? Hiring high-end treatment planners. So labs need to hire high-end dentists or clinicians, periodontist specialists to work for the lab.
Right.
And understand, and CAD designers with treatment planners, and then the dentist will take advantage of.
Well, and you imagine it, say, as a surgeon, right? Having that on your team with your referring doctors, knowing that when a treatment plan is submitted, that you have another surgeon and a prosthodontist and people that are evaluating what, like you say, what's possible, so that instead of, you doing this beautiful surgery and then having someone who doesn't know how to manage the restorative outcome, at least that it's possible.
Yes.
And then it's just a matter of, can we train the clinical skills to be able to execute the plan? But no longer is it, well, the plan was never going to work from the beginning. And so that outsourcing seems like a great place to start. So if someone wants to get involved with this, where do they go? Where do they start?
So the 2 biggest benefits here, you need to use technology to help you make better decisions, and you need to use technology to take advantage of collective intelligence. For me, one of the best things that digital brought to us is collective intelligence, meaning making less decisions by yourself. Before, you needed to be a part of a study club, you needed to schedule a meeting with your ortho and your periodontist, and you could only do this once in a while for a few patients. Now we see 20, 30 new patients per month. The ideal is to have a workflow that allows you to have collective intelligence playing and benefiting 30 new patients per month. So asynchronous communication, cloud dentistry, very simple. You need to build your team as a young practitioner. Who's the periodontist you want to consult, what is the orthodontist and the lab, and create a simple chat group and ask the lab to generate 3D images that you can share with the group, and in a synchronous way start to brainstorm daily about every single case. This is for me the most simple way to benefit tomorrow morning from technology, making better decisions through collective intelligence. Less decisions by yourself. You know, since all the patients are digital, you know how to send this information to a safe cloud system. You connect with the chat system to everybody. You type some questions. Everybody's answering, and when you open your phone again, you have these beautiful interactions happening, and every single day you're going to make better decisions for your patients.
No one wants to be alone in practicing dentistry, and I think one of the things that we've talked about on the show before is that medicine has figured out some things about the group practice that's worked well, because I can walk right down the hall and talk to the specialist. I have a morning rounds with all of the specialists in one room, speaking over a patient, talking about our plan, and therefore the standard of care raises.
Yes.
And I think that this model of cloud dentistry, where we're putting together a team of people, the 3D treatment planning team, or even
and they don't need to be under the same roof.
That's right.
Because the data is something that if we collect properly, everyone can see it.
The next level, right? What you said is bring specialists to the same office, and that is already an improvement. But that's how I work my whole life. But that's not the solution. Because even working all the specialists under the same roof, you never have the same 5 minutes free at the same time with the others. And it's crazy. So asynchronous communication through digital platforms is the only way to really do interdisciplinary dentistry, interdisciplinary treatment planning.
What's next for Christian Coachman?
Oof, there's so much, you know, just based on these projects and ideas that we discussed here, you know, there's so much to be done in terms of streamlining all of this. You know, I think that the last decade for us was the decade of consolidating these pioneering ideas. The next decade is about simplifying and spreading these ideas, making it possible for more people, you know. So I don't think the next decade will be about great revolutionary ideas. It's much more about taking the great ideas we had for the past 10 years and make it more affordable for everybody.
Wow.
This has been amazing.
That's been amazing. Well, thank you for being with us today. It's been great to hear your passion behind what you're doing, and I think it's challenged us to think more about how we can implement this into our practices. And for those of you who are listening, we know that you're thinking now, you get your brain spinning. So obviously go check out what Dr. Coachman's doing, and thanks again for being with us.